This conference will now be recorded.
All right, so I would like to welcome Joe Wyboda. You all know Joe. He's the CIO here at Rural Health Innovations, and he is going to lead us through the first part of our webinar today. And so there is our PowerPoint, and I'll turn it over to you, Joe.
Right, thanks, Angie. Good to talk to everybody again today, and we're looking forward to having, a conversation about recruiting and retention around HIT professionals. So we're talking about recruiting folks for working in HIT, not for recruiting students. I know we've talked about that in the past. And I'm going to give some examples and some things that I've experienced over time. I'm also going to rely on some outside data that we can hopefully talk about too. You know us at Rural Health Innovations, and like I said, today we're going to talk about trends in HIT professional roles in rural, focusing on rural, and there certainly are some interesting trends there that are unique to rural. Talk about some of the challenges of recruiting HIT folks, particularly into rural, but some of these challenges are nationwide. Then I want to get us to have a little discussion, and like Angie had mentioned, I've got some clarifying questions that maybe we can focus on to help us have a conversation about some of those challenges and maybe share with each other some example best practices and experiences around recruiting and retaining healthcare workers. So I'm looking forward to this conversation. So let's start out by talking about trends in HIT. Some of this is from my own personal experience, some of it's from talking to you folks, and also looking at some data from HIMSS. So one of the things that I think we have talked quite a bit about on other webinars was this lack of a clear role definition or even a job description around HIT workforce. I'm going to show you some example job descriptions in a little bit, or at least some short job descriptions that'll really show you that there's a wide variety of what an HIT job might look like. I've said before, it's like we're in the 1980s or 1990s computer science kind of paradigm where we're still trying to figure out what that job role is, kind of turning the education into a vocational training, and that's a little bit tricky right now. One thing that has been an issue in HIT for a number of years is the salary versus other industries, and I think we've seen that change a little bit. You could oftentimes make much more money working in IT in a small bank or even a school district than you could at the local hospital. And I think that has started to change. We're starting to get more parity. The interesting part about that is, having worked in other industries, I can tell you that healthcare IT it's a much more difficult specialty than perhaps banking IT or working in an educational, an independent school district, for example. There's a lot more you need to know. If you think about an HIT worker has to have some understanding of the billing process within the healthcare organization, which is extremely complex. They have to have some understanding of how the work is carried on in the laboratory, how radiology workflows are designed, not to mention clinical documentation. It's incredibly complex, and we've traditionally paid a penalty for working in healthcare in IT, and we're seeing that change now. Part of that is due to the fact that IT has not been a profession within healthcare for very long, and I think there's that value of the HIT workforce that really has not been understood. So we're getting closer to that point where people are understanding that value and not looking at HIT employees as merely a cost center, that there's somebody that adds, value that outweighs their salary. I'm finally going to talk next about some HIMSS data. If you're not a member of HIMSS, you may not be able to get all of this data. If you're not a member of HIMSS, I would encourage you to join. It's a great organization for healthcare IT professionals, and they have a workforce survey that they do every couple of years. The most current one is the 2014 version, and there's some interesting information in that. It's about a 60-page report, and I pulled out some items from that might be of interest for our discussion today. And then I also referred to the HIMSS annual compensation survey. Every year HIMSS does a survey of health IT workers, and I will warn you that survey is skewed towards urban, primarily because there are not that many rural HIT employees, HIT folks that are members of HIMSS. HIMSS has worked hard to try to bring rural folks in, but the fact is that the vast majority of HIMSS members are indeed urban. And at this time, the compensation survey from HIMSS doesn't really split out rural very well. Another kind of confounding factor with the compensation survey is the lack of clarity around job descriptions. And in the compensation survey now, they are listing what the job descriptions they use are, and some of those are going to be unlikely to be in a rural organization, and I'll go over some of those in a little bit. So first off, let's talk about the workforce survey. I believe you do have to be a member to access the workforce survey. I have a link on the bottom to that survey. It's pretty interesting. They actually have a section on barriers to fully staffing HIT. So they'll ask hospital or clinic IT organizations and say, if you're not full staffed, what are the barriers to it? The number one barrier was lack of a qualified local talent pool. Having folks that are in the community, local, that are qualified to fill the role. And that speaks to the value that you all can bring, right? Because you're trying to build that local qualified talent pool. Another barrier that they're seeing is that the hires are being taken away by more lucrative offers. I know that's a big problem in urban. I've heard about that a lot. But I've also seen it in rural. And this is, I've seen folks that will get the HIT training and will want to, decide to move to an urban area to make some more money. Or even, I've seen quite a few folks that have left healthcare to work for the local school district or community college. There seems to be a really big link there. And the folks that I've talked to were that the pay was about the same. But when you think about the hours that a health IT worker in a hospital, in a rural hospital primarily, that they have a 24/7 job, it's really can be very difficult because they may be, one of a staff of 2 people or 1 person even, and when something breaks at 2 in the morning on a Saturday, they're on the hook. So it can be a very challenging position and very difficult. Consultants are too expensive. That came out very strong on the survey as a barrier. Oftentimes organizations want to bolster their staff with consultants, and they're just very expensive. And that has been the case in rural, that we're seeing consultants being very expensive that are healthcare IT consultants. In many rural areas, there is a highly qualified computer networking expert that is probably more reasonably priced. So that's not always the case, but generally consultants can be very, very expensive and difficult to find and to keep and to hire. So that's been a pretty significant barrier over the last years. And it is important to keep in mind that healthcare is a little bit unique this way because we have quite a bit of work. We have very complex IT systems that are somewhat immature, and we have this 7 by 24, 365-day requirement in a hospital. In a clinic, it's a little bit more relaxed, I guess you could say, in terms of the hours, but there's a lot of pressure there. So as far as recruiting goes, we see from the HIMSS workforce survey that staff referrals were by far the #1 tactic for recruiting and the most successful one. That going to the staff and saying we're looking for somebody to work on IT, and this doesn't include incumbent workers, but by going to the staff to help find those folks and maybe even giving a referral bonus, that is by far the #1 tactic. In the 2014 survey, we saw quite a bit of activity around LinkedIn, Facebook, and other social media being effective for recruiting. I really think we're starting to do that at the center and RHI. When we hire folks, we're advertising on Facebook and LinkedIn. Very cost effective, really large reach in terms of how many people you can have see those ads. So that is getting to be a pretty commonly used method for recruiting now. So this is the HIMSS workforce survey. If you haven't seen it, I encourage you to download it and take a look at it. There's some good information in there. These are some of the example job descriptions. This is very small writing, and we'll have the presentation available for download. And these are some of the job descriptions from the compensation survey. And they're kind of brief descriptions. You can see some of these are probably not positions that you'll see at a rural organization. And that's why I think it's important, A, to take the compensation survey with a little bit of a grain of salt, but B, I think we can learn what the requirements are for HIT workers by looking at some of these job descriptions and really understanding what the industry as a whole is looking for, what those positions are. So you can see there's a clinical systems analyst here that has some detail on what that person does around current operating procedures and clarifying program objectives. That there's quite a bit there. It's probably not likely that we're going to have a clinical informatics director, right, at a rural healthcare organization, but some of those job duties underneath clinical informatics director will be something that you would see at a rural place. So training, evaluation, maintenance of software, that's all stuff that is listed under that job description, but oftentimes whatever the title they use at the local critical access hospital for the IT worker, that's part of their job responsibilities. Here you can see Director of Information Services. That's a term or a title that we see a lot in critical access hospitals, as the person who's ultimately responsible for IT, and that's a pretty accurate job description. Same thing with information security specialist. That's a role that you probably won't see dedicated at a rural organization, but you will see all of those duties rolled up into somebody, and it'll usually be Director of IS. So there's something to learn here. If you're looking for job descriptions, there are a couple of places that have job description banks that you can download information. HIMSS has some more detailed job description stuff. If you're a member of CHIME, It also has some job description stuff in it. Salary.com actually has some fairly good job descriptions. And here are some other examples from the compensation survey. Medical records director is one that I think sometimes we'll put IT underneath or within medical records and make it part of the responsibility, especially at a clinic where maybe it's a smaller organization and IT reports up to medical records. Usually we won't see a product architect, probably not a programmer analyst, but everybody has that project manager hat that they have to wear in IT. So my point of this is to kind of show you some of the job descriptions that HIMSS uses when they're doing the survey for compensation. And think about this as somebody is filling their compensation survey out, that they have to select their job description from that list. I've filled the compensation survey out a number of times. And you have to select from that list your job description. So some of these may not be perfect fits for rural. It is more designed for urban. So with that, let's just go on. I do have a few other job descriptions for you to look at too. So let's take a quick look at some of the salary information. And these are the average salaries nationwide for health IT workers within those job categories. So take all those job descriptions and then they get bundled into different categories: executive management, senior management, department head, manager, staff, and associate staff. You can think of staff as being project manager, system analyst, some of those positions. Associate staff would maybe be security folks or networking folks. And you can see the salaries here. Again, it is really kind of designed for urban, and I think that it is pretty skewed urban, which is going to be a bit more expensive. If you're a member of HIMSS, you can log into the site and break this down by your region, select your region, and see what the average salaries for particular job descriptions are. So that can be very helpful. The one thing to note on this, if I had trends over the years, we've seen a significant increase in the salaries on the HIMSS compensation survey. So maybe you're not paying $104,000 a year for IT director, but to know that over the last 5 years we've seen a pretty significant bump in pay for that person, you can expect that that those people are getting closer all the time to, probably a number closer to that, at least in rural. So some of the challenges from in recruiting that I'm seeing and that we see from the workforce survey, and I've heard from some of you, again, is this talent pool question. Where do we find that talent pool? What's the definition of the job description? Perceived value versus cost. You saw some of those salaries. Those are pretty stout salaries. And when you think about, you have to provide that level of value to the organization before they're going to want to pay that kind of salary. So, IT still has to do a bit of work to demonstrate that value, I think. And we're probably getting better at it. But in the meantime, we're seeing a lot of pressure to keep the salaries as low as possible, just because of that high expense and lack of perceived value. So it's about time we demonstrate that. When you think about incumbent workers, one of the recruiting challenges that I've seen there, and this is one question I'd kind of like to hear what some of the grantees have to say about this, because you're closer to some of this because many of you are training incumbent workers. But having those additional job duties did not necessarily translate to an increased salary. This is kind of a little bit of a dilemma, because oftentimes you're taking, if you're training the clinical folks to become HIT experts, you're taking some of your more talented clinical folks, whether it's a nurse or a lab tech, and you're giving them HIT training and moving them over to maybe adding some HIT experience. They're already pretty highly paid in their clinical role, and to move them over with HIT, if they're HIT exclusive, that they may not get an increase in salary. I've seen folks that have gotten a decrease in pay by moving over to health IT. So those additional job duties that don't necessarily translate for an increased salary for those incumbent workers, and I think that's something that has been difficult challenge, and I've seen folks leave organizations because of that. That if they can go somewhere where they can be purely working in IT and get a little more money, that they'll move. Talented staff moving into additional HIT role, like I just mentioned, you're taking some of your most talented staff, training them to do HIT, and replacing a lab tech or rad tech is really tough. Nursing, it's tough to replace those folks, and these are usually your more talented staff that want to take on HIT. So that's certainly a barrier. And this I mentioned earlier, it is really tough in IT to be an IT worker, rather, in a critical access hospital. Because you're kind of operating in a small team at best, and sometimes alone, and you have to be 24/7 by 365. That's a tough position to be in. I've done that, and you sleep with a phone or a pager and wait for it to go off in the middle of the night, or upgrades, which are oftentimes very frequent, have to occur at strange hours at a hospital. It's a little easier at a clinic, but again, clinics are even smaller staff. So those are some of the challenges I see. And we're at that point where we'd like to have a little bit of a discussion, and if necessary, I'll call some folks out, because we'd like to really talk about some of these issues. Some of the questions I brought up is, how are your students being placed in the healthcare facilities? How do they get jobs in a healthcare organization? How are they getting placed? What are those job descriptions? What are you guys seeing? Are you seeing that HIT salary demands are affecting your members? How do they see HIT folks as being too expensive? I'd be curious as to what your experience is around the salary of HIT folks has been. Do your members offer perks, benefits that are unique to your HIT workers? So a good example of that might be the ability to work from home as much as possible, or work remotely. I've seen that at a few places. How do the hospitals manage those demands for a limited HIT staff? This is one that we see. We see a lot of unique ways that people are trying to work through that one. And how does compensation of those incumbent workers change? So if you take a nurse from the med-surg floor that becomes HIT certified and trained, and are they getting any additional compensation? And what benefits make that role attractive to them? And do your healthcare facilities have retention plans? Do you have plans for and processes for retaining those folks? Valerie has some good comments, and I'm just reading those. You know how hard it is to talk and read at the same time? She says that practice specialist 1, 2, 3 and HIM specialist 1, 2, 3 are the popular job titles. that you're seeing in your rural areas. Yeah, I'm seeing that too, especially at clinics and networks of clinics. Nice to see the starting salaries that Valerie listed in there, and her evaluation plan will show some of the most current job titles and salaries. That's awesome. And if anybody would like to chime in, I would certainly appreciate that. Otherwise, I'll go down the list and ask some questions of those of you who I know are doing some interesting things.
Hi everyone, this is Angie. So is there anyone who is on the call that can speak to any of the questions that we have? And someone's got us on a music hold. If you could take us off hold and mute instead. Thank you. Looks like Darnell is typing something.
Okay, I'm a big fan of jazz, so I guess I don't mind the hold music as much, but whatever. You can't tell who that is, Angie, and put them on mute?
Yeah, that's what I'm looking right now.
Okay. We had a couple of folks comment on the side. Darnell said 3 of our 5 graduates received job offers from their internship site. The other 2 are not available for employment right now. C says that a few students that have taken the HIT course have excelled into informatics trainer positions in their organizations. They have excelled in training sessions and implementation of the EMR systems in their facilities. That's awesome. So Lacie, could you expand on that a little bit? Are they working in a hospital or a clinic? And if they've excelled in those informatics trainer positions, is that translating into a different job role for them, or is it kind of temporary?
Hi, can you say? You can. You know what? I'm going. You all. This is Angie. I'm going to mute all the lines, and then Joe and is this Lacie? Yep, this is Lacie. I'm going to have you to unmute your line by pressing *2 in just a minute, but I'm going to mute all of the lines right now so we get rid of the hold music.
Will do.
And then go ahead and press *2 to unmute.
Okay, can you hear me now? This is Lacie.
We can. Yep, we can.
Oh, okay,
Hear you great.
That's better. Thank you.
Perfect.
To kind of answer your question, Joe, some of the folks that work at the Horizon Healthcare clinics have actually changed their roles from working with CQI committees and actually have developed into the implementation trainers. They're actually going through an EMR search right now, and those folks are going to be core team members as far as the implementation training and layout goes when that comes around. Some of my students up in North Dakota that have recently taken the course this last year actually have kind of led and piloted a project dealing with their finance conversion of the EMR system as they've taken on another clinic. So most of them are working in the FQHC layout and have done really well as bumping themselves up and making themselves the stronger leaders and taking on those projects and working with the training initiatives. So that's kind of what we're seeing.
Okay. And what makes them want to do that job? Is it job satisfaction? Do they get a bump in pay? You know, what are you seeing, Lacie?
I can't answer on behalf of the North Dakota folks if they've gotten raises, but I know here with the Horizon crew, because I'm also kind of helping out on the EMR side of things too, but they've become more of that, not the director level quite yet, but close. They're more into the committees and more in that decision-making process. So they've really grown in that satisfaction and kind of have become a mentor to their peers. So they've really taken on that role and shown true leadership. So it's been good.
Okay, that's good. Yeah, compensation isn't always just about money, right? I mean, sometimes it's about challenge. Yeah, seeing results, making a difference. You know, that's important to a lot of folks. So, cool. Anybody? And I've been talking with Scott about some of the selection stuff you guys are going through too. So, that's awesome. Did anybody have any other questions for Lacie or anything else that you'd like to add, Lacie? Thank you for your courage of speaking.
This is Angie. Valerie had typed in the chat box that most of their graduates have been hired through a temp agency that is performing master patient index cleanup by patient matching and reporting for ACA and population health by working with the contract temp agency. They have the opportunity to apply for internally posted positions within the healthcare system.
Okay, that's kind of interesting. So they're doing MPI cleanup, and that's kind of an interesting thing. So they're getting close to the population health work that's going on. Interesting. Valerie, are those folks that are primarily trained in health IT, or are they trained around health information management, kind of the medical record side, or a little of both? And I see Valerie's typing.
And just a reminder to everyone that I did mute everyone's line, so I encourage you to press *2 to unmute your line. If you can share anything with us in regard to some of the questions that we have listed, that would be really helpful.
Okay, and Valerie says they have both pieces of training as they complete a certificate in health informatics and an associate's degree through the grant. So, in case you're wondering how Valerie's doing things. But that is really interesting, going through a temp agency to do MPI cleanup. That's a really nice partnership, because I know a lot of healthcare organizations that are going through electronic health record implementations or shared data repositories, that sort of stuff. They really do need to do a lot of MPI cleanup, and some of it is just very tedious work. And going through a temp agency like that, that's a really good idea. I like that. Thank you for sharing, Valerie.
Joe, this is Sandra from Montana. I will be happy to comment if now's a good time.
Now's a perfect time.
All right. We did a survey with our critical access hospitals and sent the survey to the CEOs and the administrators. And when the results came back to us, it was kind of a dismaying in that they did not realize, I don't think, the value of the IT staff, as you had alluded to, demonstrating value versus cost. And I would say most of our very small hospital CEOs unfortunately don't have IT very far on the radar. When they do, and for recruitment and so on, it's actually word of mouth and kind of, as you had suggested, talking to their staff and seeing who the staff might know, or just loading those duties onto somebody else. For us in Montana, I think we need to just develop the awareness that your future payment will be very heavily dependent on how your IT staff can keep your hospital reporting data, and so that's something that we see going to a very baseline level, is helping the CEOs and the top administrators to really realize the value for IT there. As far as wages go, I'm just looking at a Montana Department of Labor report, and the average annual wage for medical records and HIT staff for 2014 for Montana was about $35,000 a year.
Mm-hmm. Yeah, Department of Labor still is combining medical records and HIT.
That's really a challenge, I think. They need to split those out.
Yeah, and you know, I don't know, I don't have any data on this, but I've heard that the medical records wages have really kind of stagnated, and you know, like the HIMSS survey shows, or has shown over the years, that there's been increases in HIT payroll pretty steadily. So yeah, to combine those doesn't make a lot of sense, but that's all the data we have right now. So that's a little frustrating. I am curious, Sidra, about the, I'd like to explore a little bit more about this perceived value. And I think you're right on the money that we need to build awareness and show the benefits, right? I mean, it's like a return on investment. Are you guys doing anything like that, or do you have any ideas on how to?
We are developing a presentation or a learning module that we hope to present possibly at the Hospital Association meeting or the Primary Care Association meeting, anywhere where we might have a good audience, to really talk about that and draw the association between payment models and the role of IT. So we are, again, trying to do some training and develop some awareness that way.
Okay. Did you have anything to add, Sidra? I mean, Montana is probably one of the best examples of this issue about the 24/7 requirement being a barrier to keeping good HIT folks. Has that come up? Have people expressed a lot of frustration around that? And that would be, you know, employees expressing that, not necessarily employers.
Yeah, Joe, I haven't heard anything real specifically about that, so I'm sorry I don't have any input there.
Okay. Anybody have any questions for Sidra at all? And Tracy Mastel has a comment, and she says that most of the facilities in our network also think of HIT as just IT, maintaining the networks, keeping things up and running. It's a big role for HIT, but it's not all. It's a smaller part. We found them to not be very open to expanding their staff in these areas, either due to lack of funding or fear of someone taking their coveted job in the rural area. So the students we've trained are almost all in other parts of the organization and are doing whatever they can to move HIT initiatives forward from the ground up. Yeah, that's a good summary, Tracy, because I've seen that as well. I worked with a home care agency, or I'm sorry, a hospice agency. And, you know, it's pretty hard for a hospice agency to have a full-time health IT worker. They actually had one of their billing folks went back to school and got a bachelor's of science in IT and was trying to apply it as much as she could at her job. And, you know, they utilized her quite a bit for as much as they could. But she was really, you know, vocal that she really wanted to do more and more IT. And she had brought them pretty far forward on their their hospice application, which is a very different kind of software than a clinic or a hospital runs, and they were doing some pretty incredible things. But she was open with management and others about how this is her passion, and she's considering leaving. And she didn't want to leave her rural community. She really didn't want to work at a hospital, and it was hard to get into the hospital, like you said, because there's not a bunch of jobs that were available. So that's a tough one, and I'm not sure how we resolve that. I think maybe it'll change over time, but it is tough, and I kind of encouraged her to maybe look at working for the vendor if she was going to leave, because the vendor really admired her and thought she did great work too. So you know, it's really hard. And I see Tracy's typing. Anybody have a similar experience or opinion about that side of hiring? And don't forget, if you want to speak, which I encourage you to open your phone line, you have to hit star to unmute your line. And Tracy says people who finish the training are also frustrated because they've been given additional responsibilities now that they have this training, but they're not getting compensated for it. Yeah, I think we're still at that point. Tracy, is that primarily because these are already quote unquote expensive individuals at the organization, whether they're nurses or lab techs, that they're already folks that are pretty heavily compensated compared to what they expect to pay for IT? Lacie has also seen that with a few students, the same complaints, the majority of those are coming from clinical staff members. Yeah. And Tracy says sometimes, but not all of them, in response to my question.
Joe, this is Cindra again. One of our students is an RN and was in, or is still rather, in the quality improvement department. And she has said very specifically that many of her quality reporting duties before she took her class, she didn't know how to extract the information from the system. And it would take hours and hours and hours to get the required reporting up and running. But with the help of her new skills from her HIT courses, she can do it much, much more efficiently. So even though she's been trained in IT, her duties have become much less cumbersome because she's more efficient with it.
Mm-hmm. Yeah, I think I don't think we do a very good job as IT folks, HIT folks, in advertising where we save money and where those savings are. And a lot of that is so soft, and sometimes the financial folks really don't believe it. I had a situation where during a contract negotiation with a vendor, I was able to save $1 million. And I pointed that out to the leadership there, and they said, well, that's your job, isn't it? I mean, you know, so it's like, yeah, but this is why, you know, you have somebody who has an expertise in it. And I think we have to do a better job of doing that kind of return on investment stuff, because I think we have to, we have a ways to go to demonstrate our value, and there's so much value in clinical IT, in doing the IT right, and really improving the processes internally. Get some more comments come in. When I asked Tracy about about the salaries, she said some are CNAs, HIM professionals, radiology techs, so they're not as highly compensated as other clinical staff maybe, and they're not getting any additional reimbursement. Valerie says we've worked very hard with our apprenticeship sites to create a value proposition for many of the reporting requirements and utilize Microsoft Excel and understanding of database operations and applications. Also, you have to think about the soft skills training provided, which unfortunately online training alone does not lend itself well to developing these skills over time. We have found that the hybrid model works best through this grant process. Excellent point. I think that the soft skills are so important in IT, just because everybody says we speak a different language, and we've had this reputation in IT of being less than friendly sometimes. So those soft skills are very important. I think it's interesting, Valerie, that you're already doing some of that understanding of the value that the folks are bringing. And anything you could share on that would really be helpful, I think, to many of the grantees and me. So if there's anything that you're willing to share on that value side, I'd certainly be interested in seeing it. And I'm begging, please. Anybody have any experience around that 24/7 issue, especially in hospitals? I know a lot of hospitals, critical access hospitals, will use contract staff primarily for their pure IT, the networking and computer stuff, and then maybe have a IT manager or IT director. I'm wondering if anybody has any thoughts or comments around that 24/7 issue. Because I know in a critical access hospital, you can really feel like it's you against the world and you're all alone. And if you'd like to chime in vocally, please do *2 to unmute your line. And Valerie said that what they learned when they first began the process was that, and then it scrolled, was that the clinical provider was the one who was reporting the data and information necessary for different programs they were participating in. So they viewed that as an opening to utilize our students as an individual who wears multiple hats within the organization and takes some of the burden and load off the practice manager and providers. Yeah, that's a good way of looking at it. And nobody has any thoughts on the 24/7 issue. That's kind of interesting. I know we're kind of focused on training, incumbent workers or new HIT workers to the workforce, and that sometimes is not the issue with those folks. It's the more experienced HIT folks. I do want to be sensitive to time and leave some time for either Cassie or Katie or Natasha or anybody if they'd like to give any updates at the end as well. And Valerie kind of talks on one point, which can either, I've seen this be a benefit to working in a rural facility or also a barrier, is this idea of multiple hats. I've worked with critical access hospitals where the person who directs the IT also is in charge of maybe security or facilities management. That multiple hat thing can be very exciting to some people, and it can be very frightening to others. And Valerie says that I think some are shocked because they're expecting to enter an office job that is 8 to 5, but we don't live in an 8 to 5 world either. And that's very true. Even in a clinic, doing IT stuff requires a lot of after hours time and weekends. There's no doubt about it. Did anybody have any final thoughts or any best practices that they would like to share around recruiting, retention of folks once they get placed into the job? Otherwise, I'd like to see if we had any updates or announcements that any of our friends from HRSA would like to make. I see Cassie is on.
Hi, Joe. Can everyone hear me?
I can hear you.
Awesome. So thank you. I'll just chime in and say I don't have a ton of announcements, but we did send out email instructions about no-cost extensions that'll be coming up in July for those that need additional time to achieve any of their program goals that won't be wrapping up by the end of the grant period, which is August 31st. So if you have questions about your no-cost extensions or want to run anything by Katie or I, please feel free to do so. And then look to submit those in EHB in mid-July by July 20th at the latest. And then I also I've had a couple calls and I've mentioned this to some of individuals that I've talked to, but we're going to have a couple of